then we now have Paul Werker coming on the stage, and he's going to talk about the philosophy of surgical treatment for Dupuytren.
Thank you, Anna. I've actually changed my title a little bit because it is really going to be a plea for to start at least your treatment if you're a hand surgeon with minimally invasive treatment. So these are my disclosures. You've seen them earlier. Who in the audience is a surgeon who is doing needle fasciotomy? Can I see hands? That's good. That's quite a lot. And who is doing it as a first choice in the majority of cases? Yeah, still, well, let me try and convince you that it's a good one. First of all, my history, when I did my training in the 90s, 80s and 90s, the limited fasciectomy was the only way. And it was only in 1999 and 2000 that I became aware of needle fasciotomy. I feel a bit ashamed about that. So just like Charlie and Gary, I went to Paris and I very much enjoyed watching the rheumatologist doing needle fasciotomy. I was really impressed by the good results they achieved. So I went back to Zwolle where I was working then, and I wondered what is actually the place of needle fasciotomy? What should we do? Is it something that we should do on a regular basis, or is it just one of these gimmicks? So we started a number of studies, which are all in the literature, and gradually Dupuytren became my most important research line, and you've heard all sorts of talks, you've seen the publications, some of the PhD students are sitting here. And it also creates the biggest of my caseload, apart from also the microsurgical procedures. I don't use the microscope on a regular basis for Dupuytren. I only use it when I can't see it anymore. Anyhow, gradually over the years, my algorithm for treating patients has changed. And before I dive into that, you have to realize that we have a very high prevalence of Dupuytren in the Netherlands. About 22% of the people of over 50 years of age have Dupuytrens. Luckily, the majority, 80% of them, have only the subclinical form, so we don't see them, and the 4% are the patients that we see. If you look at them 7 years later, then you can see that there's a progression of 21%. That's work that Bente has done. And there's also a regression in some of the cases. So it is, as you all know, quite a disease. Now, if we focus on that clinical form, then I'm getting more and more convinced, and Wolfgang has already said it in his introduction. Geiserian said there's a form of Dupuytren that he called the non-Dupuytren Dupuytren. And I'm not sure where that is, but I think that I would like to distinguish, first of all, the typical form of Dupuytren, which is a man of about 60 who's had a nodule for about 10 years, one raise involved, it's unilateral, 1A too many I see now, and he has an MCP contracture. And then I think you should try and distinguish the ones who have skin involvement and the ones who have a cord that is really not attached to the skin. I'll come back to that later. And then, of course, we have the diastasis form, the young patients with positive family history, bilateral disease, radial involvement, MP and PIP is contracted, and the skin is very often involved. And then on top of that, we have the so-called problem cases. Those are either the diabetics for me or the patients that you think are just the typical form, you operate on them, and then all of a sudden you have this huge problem because they have, within a few months, they have even a worse contracture than before you operated on. And I'm really scared for that category because I'm not always sure if it's the color of the eyes or something else that causes this. So if you are talking about treatment algorithms, I think you can look at it at least two ways. You can, as far as I am concerned, distinguish what you do for the typical case and the diastasis or the problem cases, and you can look at it in terms of efficacy and durability. Just an in-between, an indication for surgery, for me, is any progressive contracture of any joint or web space. So I don't have a figure, I don't say, now you have 29, so I can't operate on you, and 31, yes, we can go ahead. Progressive disease that causes trouble, I like to do. Not an indication for surgery, not even if the finger is really bent, is a stable contracture and a painful nodule, because that painful nodule eventually usually becomes less painful, or you can give an injection or maybe even radiotherapy. We hope to find out whether that is a good idea or not. Once again, if you look at typical versus diathesis, then I'm convinced now, after all these years, that if you have a patient with a true diathesis, I think you need to hit really hard the first time. And very often in these cases, I do a dermofasciectomy and a skin graft right away. I may start with a limited with a PNF, percutaneous needle fasciectomy, but I usually tell my patients, you know, you are young, you have this disease, it runs in your family, so I think we will not going to have a good result. You want to give it a try? Okay, but be prepared that within a few months that you're back, and then we really have to hit hard and do the dermofasciectomy. But so, because the rationale is I want to take away as much of the volar fascias and most of the palmar skin of the finger, because I think that the skin really plays a very bad role as a source of the contracture and of the recontracture afterwards. And if we remove the skin, then you're very less likely to see a recurrence. And strangely enough, it seems that afterwards it cools down the process. If you see these patients after dermofasciectomy, in general, they have much less activity than after a selector limited fasciectomy, in my view. But there are also disadvantages, and you have to bring those across, because it's a longer surgery. It can be very tedious, especially if it's a recurrence. Are there more complications? We'll see, or we have seen already. Yes, especially if you have to do it as the so many surgery. There is an extra wound, an extra scar, which not always is as nice as you hope, and it might be a longer convalescence time. If you look at the other way at your algorithm and you put efficacy opposite durability, then that's a very important discussion for the patient, because what do you want? Do you want to be back in your job or in your hobby tomorrow, or do you want to have a more durable result? That's the discussion that I have. And in case of a contracture with a total passive extension of less than 90 degrees and no diathesis, I think you can do whatever you like, and I like the minimally invasive procedures, because the efficacy with below 90 degrees, we already showed that in 2006, is the same for the three treatments. Obviously, a downside of the minimal invasive structures where you don't remove any tissue is that you have a less durable result, or a higher recurrence. But I am a big fan of PNF, because it is not only nice to do for me, but that it's not relevant, but it gives a much quicker recovery, and it can be repeated with absolutely the same efficacy as the first needle fasciotomy. And if it doesn't work, it's just bad luck, then we can move on and do something more aggressive. It at least delays a more invasive procedure, and we have shown that the older you are, the better the durability of needle fasciotomy and also of the other procedures. And last but not least, you get to know your contracture, because if it repeats very quickly, then you have to be prepared to do something more aggressive. And sometimes it's absolutely fine. And if you decide on a limited fasciectomy, you have to know your anatomy. And of course, the work that McFarlane did in the 70s is absolutely instrumental, but please also be aware that in the last 10 years, we have published 3 papers on the anatomy and on slight changes that we have found and that might influence your decision making. Now, the incisions, you can use any incision that you like, and this is only from the book of Green, the 4th edition. So in the meantime, we have seen a slide, I think today, where there are other types of incisions that you can use. I use the Skook incision with the Z-plasty at the level of the proximal phalanx. And so that is how I manage the skin, and I excise the fascia, and excise not only all the pathology in the surgical field, like the pretendinous cords and the prelumbrical cord, but also in the tetary ligament, the palmar digital spiraling system. And if you do not know what that is, please go back to the anatomy that we published recently. And Grayson and Cleland, I also excise. And I also excise in the operating field all normal-looking fascial tissue. So you may wonder, is this a limited fasciectomy? Maybe it's a radical fasciectomy in the area where I limit my excision. But it is something that I'm convinced of, and I still need to show that it gives better results. And then, when I still have a remaining contracture of the PIP, I do a gentle passive mobilization. I'm not sure if it's very gentle, but at least I think it's just as good as a surgical release of the joint, and that has been shown by Breed and Smith years ago. Skin closure, if at all possible, and that is the beauty usually of the longitudinal incision. You can remove some of that bad skin where there may be affection. And the closure of the Z+T allows you to recruit skin from the sides in the proximal phalanx, which works very well in my hand. The transverse incision we have seen you can just leave open because it will heal nicely and without any problems, and it allows for draining of the blood. And more proximal, the zigzag incision, you can just close directly. Now, this is a typical form of Dupuytren without any skin involvement, and any treatment will give you a good result. I do a PNF because of this quick recovery and the limited damage. And there's a relatively low chance if you would do a limited fasciectomy of recurrence of 20% and a higher chance of recurrence if you do a PNF. And I appreciate that and I accept that. Now, this is one of these typical patients. I'm going to take you through the 12 years that followed our first encounter. You see he has an MP contracture of limited proportion in his fifth and his little finger and ring finger raise. And a year after I straightened it with a needle fasciotomy, he is fine. And please be aware, there was no skin involvement, so the cord was almost everywhere. It was loose of the skin, except for the area here where the transverse ligament of the palmar aponeurosis is. Okay, here you see him at 2 years. He had a recurrence. I did another PNF. Beautiful result, not a problem. And here you see him at 5 years, where he came back. I did the third needle fasciotomy, and again, quite a good result. Now he had primarily PIP contracture, and you see that I was able to straighten that out. And here you see him at 12 years. Still doable, easy, very good result. Now, obviously, this doesn't happen always. There's also more problematic cases, like this 70-year-old woman who came to me in 2014. She only had a bit of puckering in her palm of hand, nothing else. It was, for me, it was too early to do anything about it. And I saw her in 2016 again, and I operated on her, did a PNF, and this is a year later, and already the puckering is starting again. And on her right side, you see that she has also all sorts of involvement. So 1 year later, you see she's almost back to where she was. She wants another PNF, but this really is not going to last any long. So for her, I saved a few years, but afterwards I moved on to a dermofasciectomy eventually. Now, this is one of these typical patients that we may see already in 2013. He had been operated 10 times, and he was 58. And you see him 3 years later, where he had a terrible advance of his disease. So I started doing dermofasciectomy, and for you it may be difficult to see where the skin grafts are, but this is 3 years down the line, and you can see where the arrows are. That's where the skin grafts are. And I take the skin graft all the way from the area where the skin is involved to where the disease seems to stop. So I do not do like Dominic told us earlier, to remove all of the skin from this crease to this crease. I usually go a bit further, and I even do a skin graft here for the thumb. And the biggest downside that I always warn my patients for is that they will end up with a hole in their hand. So in full flexion, like we normally close off our hand, that doesn't happen anymore when there's a skin graft. So that's something that you have to warn patients for. So how about complications? Of course, I do have them. I think that I'm the one in the Netherlands who has most of the nerve injuries, because I see all the terrible cases and I still try to get them better. But I hardly see any complications after PNF. In 25 years, I've had one patient who called me the day after surgery that he had a completely numb side of one finger that I treated. And I thought, oh, now I cut the nerve. And I operated him and the nerve was intact. So it was just a traction neuropathy, and it recovered completely. So when you choose for a limited fasciectomy or dermofasciectomy, decide beforehand, especially if it's recurrent, which structure, as far as the neurovascular bundle, you want to preserve. Because very often the ulnar artery of the little finger is very, very small, and the radial artery of the index is also very small, and you want to preserve the nerves on that side of the finger in any place. And please put in the files what went wrong, because for the next surgeon it is very helpful if you know that some of the nerves were difficult to get free. And have a good hand therapist working together with you, because you need them. So take home messages, try to identify which type of Dupuytren is opposite you or sitting next to you. And do not try to be a one-trick pony. Yesterday I was a bit annoyed about all the radiotherapy comments. Today it was better, but I don't believe that there's one treatment that can save everything. So I'm very much in favor of trying things out. So I very much support the radiotherapy work. We are collaborating with Jared in the trial. So we hope that radiotherapy is the way to go, but we need a bit more proof. Counsel based on type, efficacy, and durability, and look for skin involvement. For me, that is the key. Is that a diathesis feature? I do not know. And make your own algorithm. And do PNF if you don't do it. An early recurrence following PNF, in my view, is not a failure. And before you do your more extensive surgery, please restudy the anatomy and do not be afraid to replace the skin and report your complications. Thank you very much.
Thank you, Paul, for a great talk.
Sophie.
We've got a question.
I've got a question. I've worked with a couple of surgeons who said after PNF, I wouldn't like to go into the finger because you don't know what type of scarring there might be. In your experience, what do you see after PNF if you have to do an LF or a DEF?
Yeah, I think it's a bit the same story as with collagenase. What do you find when you open after collagenase? And maybe it's not a good comparison because collagenate, I think it makes more damage. Usually it is not a disaster whatsoever, and it's relatively normal anatomy, I would say. You have to be prepared to follow the nerve a bit along maybe a slightly different path. I don't know, Gary, what your experience is, but I haven't encountered many problems after PNF.
I echo what Paul said. Open surgery after PNF is really nothing unusual, because you're not really disrupting the anatomy. You're just releasing the cord.
I just want to add to that most of the times that's the case, but not always. And I wonder why not always. And I think, but I'm not sure, there might be two explanations why in some cases it looks like a recurrence, so it's more challenging and more scar tissue. And I think one of the cases might be, and we don't document enough, that's what you say, we have to document problems, that skin tears, big skin tears, then sometimes they can have scarring, and maybe, I will say it for the last time, I've seen it under the microscope, if you have microneuromas, that causes fibrosis too.
If you had the wherewithal to do it, would you get a polygenic risk score on patients that you thought were high risk and you were trying to decide whether to do a dermofasciectomy or not?
Well, once we had shown that at least it has the economic value that we think it has, and you inform the patient that he has had a genetic analysis and that the genetic analysis may may be used for other purposes and that insurance companies may, etc., etc. I'm not sure in which way we are going, but obviously all information that we can gather to clear the picture, to remove the fog that we are still in, that will help.
If you had a patient who, this is a hypothetical, patient who didn't look all that bad, that you wouldn't have expected to be at high risk, and somehow they had a polygenic risk score that was high, would that change your treatment?
I hope it would, but we have to do those studies.
Okay, thanks.
Okay.
No. Thank you very much, Paul.